extension and back. Most of the patient, when we give them this exercise, they come and complain of arm soreness because it's a passive physiological extension. So when you move from down to up, that's passive physiological extension. Sometimes, if the patient is having pain during extension, relax totally. I now may do some accessory client, okay? And then with the lumbar spine, we go purely PA. So I will use this nice pad in here, and as if I will lean over the patient. How is that good? Okay. Or I can use the ulnar side for each.
Ma'am, is it central or unilateral?
Now I'm doing it central. Actually, in the lumbar spine, it's very hard to do unilateral because of muscle pumps.
Right.
But sometimes, do you know the butterfly grasp? Okay. I can lay it here and do bilateral, or I can move right and then left, right, left, and it's called rotation mobilization. And I can even combine this with extension. So I will do mobilization and you push. Yes, good. And back. Again, and back. And even if the head bed goes into extension, we can make the patient on this, and we do some accessory mobilizations. So are we okay with this? Yes. Good. So that was the active range of motion for lumbar spine, passive range of motion, and we do it as passive physiological mobilization. Now accessory mobilization, we have done central segmental, bilateral, and rotation. And we have done it sustained with
Extension movement.
In this position, I can use it to mobilize the SIG joint. So we have the sacrum with limited mobility and the ilium with more mobility. So it's wise to mobilize the ilium because it has more mobility. So if I like use the ilium in here and pushed it anteriorly, okay, that will be PA, okay? But the problem might be the patient is rotating. That's why I will use my other hand and just to stabilize and do this. Okay? We can use it as a differential diagnosis. So if the patient is extending, having buttock pain, I can try extension with lumbar mobilization and with core support when it's unloaded passively. Okay? I will start with a position that it's opposite to the neural tension. Okay? So the three neural tissues pass through as brachial plexus. So any depression will put tension on the three neural tissues. So with the ulnar, median, and radial, we start with depression. Are you okay? Okay. Then I will need your hand to see here. Okay. And then I will take the patient passively with my hip. I can rotate and do with the other side also. Okay. Into abduction. Are you okay? And then I will take your hand into external rotation. How is that? Good. Supination. Extension elbow, extension wrist. And finally, I can ask you to do side bending away. It's called the passive physiological cervical flexion mobilization. No, no traction needed. Actually, traction increases musculospindle activity and I need him relaxed. Okay? And then I will try to go into side flexion, this side or the other side, and see how much range does the patient have, what is the end field I can feel, and if there are some symptoms. So for example, if the patient is having symptoms in here, then I might do one of these things. If severity and irritability are low, I will do something called desensitization. So I will push in the same direction, in the pain, and go back. That's decreasing the sensitization of the tissue. But if the pain is too much, I will move back and move just before the pain. So do not get to the painful point. Or I might move in opposite direction. And then after few repetitions, reassess. So that's passive physiological, side flexion. then we have totally relaxed, yes, the rotation. And in order to have an end range, I will use my hand this way. And then the other side this way. Also, we will have the same options. Touch the pain, desensitization, move, and just stop before the pain. Stretch, okay? And this stretch with internal rotation and deduction, increased or same? More or same? Same. Okay, and with neck flexion? How's that? More, same? More, okay, relax. So that's the whole steps. Raise, dorsiflexion,
Internal rotation and adduction.
So when the
Internal
patient
rotation,
experiences some
adduction.
tightness, it may be muscle, right? But then with the neck flexion, the pain increase. Is it still muscle or neural tissue?
Neural.
Neural, because now the dura is more stretched.
Yes.
So let's take an example for the glides. So I took the patient leg, and he said at this point there is pain. I can start to end the glide. So with knee flexion, I will do dorsiflexion, knee extension, lumbar flexion,
Okay.
and I will keep doing
Right.
this. After a while, patient is better, and then we talk him into internal rotation abduction. So in this position, plantar flexion, neutral dorsiflexion. Plantar, dorsi, or knee flexion, knee extension, knee flexion, and knee extension. Or head up, foot down, head down, foot up. So we do with that cervical and also back. And then we can use also slump, but I will do it after I do femoral. So can you turn facing everybody? Can I take this? Are you okay with that? So you can use your hand. Okay. So for femoral, I want to make sure that there is no neck flexion or lumbar flexion. Okay? And then I will take the patient uppermost leg and rest it on my hip and support the whole leg like that. Okay? And is it okay? Tell me if you want any definition. I will stabilize lumbar spine because all I need is hip extension, not lumbar extension. If I did hip extension and then knee flexion, patient said he has pain in here. It might be quadriceps or femoral nerve. So if with neck flexion, pain increased, it is femoral.
Okay.
It is already. Okay. So let's do some glide. So we will do flexion, flexion, extension, extension. Flexion, flexion, extension, extension. And I side bending the interface with moving the nerve itself. So mobilization with movement also can be form of glides plus neural glides. And then we have the last bit, which is cognitive motor control testing. Okay. And now I need you, as said, all ears. Okay. So you are going to hear with everything that you have. Right? And we have done side flexion.
Side flexion.
Now can you be facing my knee? This. And then I need you to be relaxed. If I just grab the patient this way, that will be rotation. And then I can increase the range later. Okay. And even I can go to end range. Can you straighten this leg? Straight, straight, straight. And then I will take you into end range lumbar flexion. And then thoracic, rotation. This is like a pre-manipulative, but we will use it for end range passive physiological rotation. So that may be the case. Easy? Okay. And then we will move to a prone position on your face.
Ma'am, this technique can be applied to each lumbar spine separately. Each lumbar
This is
separately.
physiological, not
Because
accessory.
combined.
It's a physiological, like when you move in here, so it's never separate. Okay? If you put your hands
Moving the whole
here,
spine.
we are here, one hand here, one hand, and then the other. And then you moved toward extension and back. Most of the patient, when we give them this exercise, they come and complain of arm soreness because it's a passive physiological extension. So when you move from down to up, that's passive physiological extension. Sometimes, if the patient is having pain during extension, relax totally. I now may do some accessory client, okay? And then with the lumbar spine, we go purely PA. So I will use this nice pad in here, and as if I will lean over the patient. How is that good? Okay. Or I can use the ulnar side for each level.
Ma'am, is it central or unilateral?
Now I'm doing it central. Actually, in the lumbar spine, it's very hard to do unilateral because
Okay,
of muscle mass.
right.
But sometimes, do you know the butterfly grasp? Okay. I can lay it here and do bilateral, or I can move right and then left, right, left, and it's called rotation mobilization. And I can even combine this with extension. So I will do mobilization and you push. Yes, good. And back. Go into anterior tent. So there is movement for the SIJ involved also. Or with my hands, if I have a lot of stuff in here. So imagine the following. If I grab the ASIS, okay, and I stabilize sacrum, and I did this, that will be
Posterior tail.
mobilization.
Posterior
So in this
mobilization.
position, we can do anterior mobilization, posterior mobilization, oscillatory or maintained, and the patient do some extension. Or we can do it in side line again facing me. Yes, and you bend your legs as much as possible because I don't want to get the hips involved. I will block the hips. And then imagine if the ilium is the steering wheel. So I will catch it with both hands. If I have a big size patient, I will use my forearms. And if I moved it this way, it will be superior, posterior. This way, it will be anterior, inferior. Okay? So I will do that. Take soft tissue and then oscillations, posterior mobilization or anterior mobilization. And then after that, see if the patient is going to have these symptoms or not. Okay? Finally, in supine position, on your back. Yeah. So we have, what did we do so far? Active range of motion assessment in standing. Any movement can be used repetitively. Okay? And then we see the effect. In passive physiological or passive range of motion, we have done knees to chest, which is flexion, gapping, rotation, and rotation in end range. And then in side line, we top the ilium either anteriorly or posteriorly. And in prone, we done accessory glide, central, or one level that can do with extension, bilateral, or rotation. And we done also the ilium anteriorly or
Posteriorly.
Okay. Now the neural tension test. And we have two options for a posterior referred symptoms, which is sciatic nerve, and then one option for the anterior thigh referred, which is
Femoral.
So let's start with the SLR. Nice, easy and loaded and passive. So I will cup the patient heel on my hand. Please relax your back, yes. Avoid causing any pressure on the superficial neural tissues at the malleoli. And then ideally I will do it here. So I'm doing it with my hand. And then what I do with the elbow, flexion or extension, extension. And then I use both hands for rotation, internal rotation. And then I ask the patient to do thumb deflection, finger flexion. I do wrist deflection and
Already mobilization.
that's it.
That's already
Same
now.
as in supine.
Just
Yes.
for ease for us to, because we in
Yeah, because
straight
now
position.
I'm staying in my position. Versus in supine, I have to go down with the patient.
Man, this is modify position for original now.
Yeah, but the only problem is that if you don't have an opening for the head, then the patient will rotate and it. Okay, and then I will take the patient passively with my hip. I can rotate and do with the other side also. Okay, into abduction. Are you okay? And then I will take your hand into external rotation. How's that? On my forearm. And then I will use my little finger as a bat and do, it's not a purely PA, it's also inclined toward the left. So that's what I will do as on and off. Or maintain it and take the patient, sorry for the messages, the vibration is okay. Okay, it's not your neck. Okay, so extension or rotation or side flexion. And then we can do also thoracic, okay? So I can maintain the patient opposite shoulder, and then I can use this grasp, okay, which is nose or rabbit ear, some people call it that way. And then I can take the patient thoracic spine also not purely BA, but toward the eye. Multiple levels till even we reach the lower cervical part. And then we can do some symptom modification here. If the patient said, okay, flexion increases my symptoms and relax, then I will do some thoracic accessory glide. Bend your neck one more time. Yeah, that's better. What does it mean for you? Part of the problem is thoracic spine, and part of the treatment will be thoracic accessory mobilization. So mobilization with movement doesn't have to be in the same region, especially if they are connected. Sometimes a bit restricted range. Okay, and can you be facing this way? I'll do it one more time. So can you see a lot of lumbar flexion, nearly no hip flexion? Okay, and up here. Do you have any lumbar spine symptoms or chronic? When you bend, any tension, any pain, or it's okay? Tension, okay. And then you put your hands in here and then try to look forward and back. Okay, but don't push your hips too much. Now go. That's it, yeah. Right? Because that's the opposite here, overloading the hips in extension. So maybe your lumbar extension is left. Okay? So let's see how we can passively assess the range and then use it later as a treatment. Can you be in a sideline position facing everybody? You can shift this off towards me. More? Can you? Yes. Okay. So what I'm going to be doing now, I need you to be totally relaxed. Okay? And then I will see how much flexion our colleague have. Okay? I have a hand in here because I wanna increase the range as in posterior tilt. Okay? So that's what I am seeing as passive range. And then relax. Relax. I can use it as passive physiological mobilization. So yeah, lumbar spine. So no, because I block the head already, and my hands here on the lower back, and trying to do some posterior tilt. So it's long. Okay, and then same position, but look back in the bed. Same position. No. Still facing back. Okay. Yeah. Okay. And then yeah, that's good. Okay. And now for side flexion. Actually, when we go with side flexion this way, it's not purely lumbar. Part of it is thoracic. Okay. So when we stand, if anybody standing want to try it, and then we bend one knee, that's a side flexion on the left side, which is straight. Bend on the patient back We have done passive range of motion for flexion and extension, retraction, side flexion, and rotation. Accessory in prone, we have done cervical, central, unilateral, and thoracic. Central, unilateral, and costovertebral. And in setting, accessory glide cervical, and accessory with physiological, and also thoracic spine. Okay? Shall we do this in a practical lab and then come back to talk about motor control or kinetic control?